So we go. Okay, so we're going to talk about eyes, vision, and visual development. I assume that you are all parents, or at least most of you are parents, and you've probably been told that your children are at risk of eye and vision problems, which needn't hold them back if we just approach it properly. And that's what we're going to talk about, how to make the most of your children's vision. Okay, my qualifications for this are that I have very recently retired from Cardiff University, where I headed the Down Syndrome Vision Research Unit, which started in 1992. And for, however, I can't subtract 1992 from 2025, however long that has been, we've been looking at how eyes and vision differ in children with Down syndrome. So it's been such a long process, you'd think we would know it all by now, but there's still lots and lots of questions that we don't have answers to. But we do know a great deal about eyes and vision. So let's just kick off with something you know, which are these features of children with Down syndrome. You know that a lot of children, particularly when they're very little, have a hearing deficit often. Sometimes it's seasonal, isn't it? Because it's mainly glue ear. But you're also aware that auditory processing is a weakness and their speech is often delayed compared to typical children. And you've probably been told, I hope you've been told, that visual processing is a strength and the children are visual learners. And I want to emphasize that because that means that if the children have visual problems, it's going to have a greater impact on them than it would on a typical child who's not quite so dependent on vision. So it's really important that we get vision right for the children. These are the topics that we're going to cover. Don't worry about them now because we're going to go through them in turn. So this is really there for people who are watching the recording. So we'll start with refractive errors. That's long sight and short sight. A quick reminder of how our eyes work. The front part of our eyes, the cornea and the lens, are there to focus light precisely on the back of the eye, where the first stage of visual processing happens on this layer here called the retina. And if you are going to see your best, you need a sharply focused image there, just like a camera. And refractive errors, long or short sight, means that the image falling on the retina is not focused. So those of you who are short-sighted, who wear glasses for short sight, will know what it means. It means your best vision is at short distances. And without your glasses, anything further away is increasingly blurred. Long sight is exactly the opposite. Your best vision is at long distances. And as things get closer, they get more blurred or just more difficult to see. Now, long sight is a little bit more complicated than short sight in that we can use the muscles that surround the lens to change the focus of the lens and overcome a small amount of long sight. So for typical children, if they had a small amount of long sight, we wouldn't consider prescribing specs because they can very readily use those muscles and overcome their long sight. And in fact, most people who do not need spectacles are a bit long-sighted and are using those muscles all the time, and you're probably not even aware of it. We'll come back to that point later. So if we look at the distribution of short sight and long sight in typical children, this is what it looks like. Percentage of subjects, and a huge percentage of typical children are a little bit long-sighted. That's what I've just said. And they use those muscles to overcome it, don't need specs. A few more are significantly long-sighted and they will benefit from specs. A few, this is at school age now, primary school, a few will be short-sighted and will benefit from specs, and overall about 6% of typical children will benefit from specs at primary school. This is the same thing with children with Down syndrome superimposed in red, and you'll see that there are far fewer children in this slightly long-sighted region, far more significantly long-sighted, and a few more short-sighted, although short sight is not that common in Down syndrome. It's a little bit more common than among typical children, but overall 60%, that's 10 times more children with Down syndrome will need to wear specs in primary school or at primary school age. That's one of the things we don't understand why that should be so. But what we know happens is that typical children may be slightly short-sighted or long-sighted at birth, and they grow out of it, all except that 6% that don't quite manage to grow out of it and need specs when they get to school or at some point in childhood. But children with Down syndrome do the opposite. They start off with small amounts of long and short sight the same way typical children do, and they don't grow out of it. So long sight can increase or even appear in the first few years of life, but it stabilizes at around the age of 4. And beyond that, the eyes stay very similar. Short sight, on the other hand, can progress until the children are around 8. And astigmatism tends to progress or develop. That means it may appear when it wasn't there before, again, until the age of 8. And I'm stressing this because what often happens is you take your little one for eye tests at the local hospital, and you are told everything's fine, everything's fine, everything's fine. Oh, he or she needs glasses. And to you, that seems impossible. You know, you've been telling me since she was a year old that everything's fine and she doesn't need glasses, and now you tell me she does. Well, the reason is that long sight in particular, and those who are going to be short sight, increases in those first 4 years of life. So unfortunately, you're not warned about that. I can understand why, if everything's fine at the age of 1 or 2, why you think you've got away with it. But these things do develop in children with Down syndrome. So before we come on, I'm going to stop sharing for a moment, because I want to show you how to tell, if you don't already know, whether your child is long-sighted or short-sighted. So hopefully you can see me now. If you set it on speaker, I'll be there on your screen. Okay, and I'm going to put a lens that corrects short sight in front of the camera. Can you see how much smaller I now look? So if you look through your child's glasses like that and everything looks smaller, they're short-sighted. Here's a lens that corrects long sight. Can you see how much bigger I look? That's a bit scary, isn't it? How much bigger I look through a long-sighted lens. If you look through your child's glasses like that and everything looks bigger, they're long-sighted. So it's very, very easy if you have not been told or you have forgotten what your child is to know whether they're long-sighted or short-sighted. I'll go back to sharing now. Now, long sight and short sight are actually defined by what is happening when the child looks at distant objects. But children don't spend much of their time looking into the distance. Children do all of their activities and particularly all of their learning at near, close to them. So what is particularly important is how children use their eyes to look at things close to them. And this is where those muscles that I was talking about come into play for all of us. If we are looking into the distance, our muscles in the eyes are relaxed and the lens is at its thinnest shape. When we want to look at something close to us, we use those muscles to allow the lens to adopt a fatter shape, so it squashes down and becomes fatter, and that allows us to focus objects that are close to us. It's the same process by which children who are slightly long-sighted can overcome their long sight. And that process is called accommodation. And this is what I'm measuring here. So Oliver here is wearing his specs. He's slightly long-sighted. He's got his glasses on and he's looking at a picture that's on the face of the cube that's towards him. And I've deliberately set it quite close to him. I'm using my instrument that we use to measure long or short sight, but in this instance, I'm not measuring Oliver's long or short sight. I'm measuring where his eyes are focusing. So I am moving the instrument to find the point at which Oliver's eyes are focusing. And what I'm demonstrating here is that although Oliver is looking at something very close to him, his eyes are focusing further away. His eyes are focusing back here. So therefore, I know that what Oliver is looking at is out of focus. It's blurred. He's trying his best, but he's not managing to get it clear. If we translate that now to a graph, and we now have 73 children with Down syndrome and rather more typical children, then this represents the distance from the child's eyes to the object they're looking at. This represents where their eyes are focused. This is the line of perfect focusing, and this is where typical children fall. So if I ask a child to look at an object that's 10 centimeters in front of their eyes will focus at 10 centimeters. And wherever I put it, the eyes focus correctly. This is what Oliver was doing, and this is what the average of 73 children with Down syndrome do. Looking at the object, focusing further away. Wherever I put it, they don't focus accurately on it. So what they're looking at is out of focus. Now, there are two implications for this. The first one is that children do not use their focusing mechanism properly. So, if a child with Down syndrome has a small amount of long sight, we cannot assume that they're using their muscles to overcome it. We can make that assumption in typical children because, as you can see, typical children focus accurately. So children with Down syndrome are much less likely to be able to overcome small amounts of long sight. So my argument is that the children's ability to focus must form part of the examination for a long-sighted child. If your child is long-sighted, we want to know whether they can overcome it, like a typical child does, or whether they need to wear spectacles to correct it. Once children have got their spectacles, 3/4 of them still have this difficulty focusing close to them. Like Oliver, he had his prescription to correct his long sight on, and he was out of focus for the near tasks I was asking him to do. So 1/4 of children with Down syndrome focus accurately. By no means all children that have this issue, but the majority of children, when they look at something close to them, are seeing it out of focus. And that's the case even when they're wearing their spectacles for long sight or short sight. So it's very, very important that children's focusing is measured at eye exams. And what we do about that is put the children into bifocals. James here is wearing bifocals. Can you see a little faint horizontal line here and here? So the bottom part of his lens is stronger to help him to focus at near. So he looks over the top of the bifocal for distance, and he looks through the bottom part of his lens for close work. And when we do that, these are the children, on average, again, who are wearing bifocals. These are children wearing their ordinary specs out of focus, as we've seen in the previous graph, but we can put the children in focus with bifocals, and the vast majority of children wear them very successfully. A handful of children out of hundreds don't take to bifocals, but the vast majority have no issues with them at all. I just want to give you a little bit of anecdotal evidence. This is Evie. Evie was 10, and the teachers were a little bit worried about how she was doing at school because Evie wasn't grasping writing. Her writing just simply wasn't coming on, and she seemed a bright child, and therefore it was very unexpected that she couldn't learn to write. So they asked Mum to take her for an eye exam, or one of her regular eye exams at the hospital, and the staff at the hospital said, we test Evie every year and her spectacles are absolutely correct. There's nothing wrong with her specs. Evie's mum emailed me, went through the Down Syndrome Association and emailed me, and I suggested she ask the hospital to measure her focusing, which they did. She was out of focus and they put her into bifocals. The teacher very kindly sent me this. This is Evie trying to write wearing her old glasses, and she's trying to join the dots and is not making a very good job of it. It's really, really hard work because Evie was seeing all of this out of focus, so she wasn't seeing it clearly enough for her to do it. She put her new glasses on, her bifocals, and immediately she did it so well she wore the pen out. So it was an instant improvement in Evie's ability, and 3 weeks after this, Evie spontaneously wrote her own name. So that's a real success story, and an example of the impact that bifocals can make on the children. So I want to show you now how we measure all this. You know when you go and have your eyes tested that you read a letter chart. Your child may not be able to read a letter chart and answer those rather weird questions that we ask. So parents always wonder, how on earth do you know what glasses my child needs? Well, it's a very, very simple technique. We use a torch called a retinoscope. So the procedure is retinoscopy, which shines a light at the child's eyes. The light at the top and at the bottom is the light coming from the torch and falling on the outside of the patient's eye. The light in the pupil here is light that's gone into the eye through the pupil, because the pupil is a big hole, reflected back from the retina, and that's the reflected light that we're looking at, because our eyes reflect light just like cat's eyes do, but nowhere near as efficiently as cat's eyes do. So our eyes don't reflect as brightly. But if you get the lighting right, you can get that reflection, and that's what we are looking at. So we've got 2 eyes here and 2 eyes here. In the top pair of eyes, you've got the light reflected on the patient's left-hand side. The patient's left is your right, okay? And that's because these eyes are long-sighted. These eyes have the reflected light on the opposite side. The reflected light is on the patient's right. In both eyes, that's because these eyes are short-sighted. So, using my retinoscope, I need your child to look at my light for 1 second, and I can tell you whether your child is long-sighted or short-sighted. If you notice these 2 eyes, the reflected light in this eye is much wider than the reflected light in this eye. This is because this eye is more long-sighted than this eye. So in that same second, I can give you an idea of how long-sighted or short-sighted your child's eyes are. And then all I need to do is to put lenses in front of your child's eyes for 1 second at a time. until I find the lens that makes the reflected light not on the right or the left, but slap bang in the middle, because the eye is no longer long or short-sighted, and that's the spectacle prescription. And it really is that easy. There are very, very few children who can't look at my light for a second at a time, a few times. Okay, so we can almost always arrive at a spectacle prescription for a child, irrespective of their ability or disability. And that's what my clinic looks like. I'm very, very proud of that photo, and I do like to show off that photo because I feel that the success depends on the fun. Okay, if the child is not enjoying it, I'm doing it wrong. If the child is having fun, then I am having fun, and it's all a huge success. So it's really, really important that patient and I laugh together. Okay, I now come to the D word, which is the one that disturbs a lot of parents: drops. When you go to the hospital, it's not universal, but many of you will be asked to consent for drops into your child's eyes. And I want to explain to you why hospitals use drops. Typical children, as I've already told you, have very active focusing. They can focus on anything. I can put a potato in front of a typical child and their eyes will focus properly on it. Their focusing ability is extremely active. And that means when we try and test their eyes and we're looking for that reflected light, their eyes are often changing while we're doing it. And sometimes they look short-sighted, sometimes they look long-sighted. It's going all over the place. So the drops that the hospitals use are designed to paralyze those focusing muscles in the eye so that their eyes are stable. And that is generally a really good idea with typical children. The other thing the drops do, apart from paralyzing those muscles, is dilate the pupil. They make the pupils very, very wide, which when you're trying to measure the short sight or long sight of a child is actually a bit of a nuisance because there's so much light coming back because the pupils are very wide that it does make it a bit trickier. But what it does allow us to do is to examine the health of the eyes very thoroughly because we can get a good look inside the eyes. Now, this is a child who's had drops in one eye and not in the other. Now, imagine my trying to look at the inside of this eye. It would be a bit like trying to look at the hall of your house through the letterbox. It would be quite tricky to see much. What we've done here by putting drops in is open the front door, and I will get a much better view of your hallway. So the drops are very useful for the health examination of the eyes. But children with Down syndrome don't have active focusing, as we've already seen. They do not vary their focusing while we're testing their eyes, so we simply don't need to use drops to examine their long or short sight. I've been working with children with Down syndrome for over 40 years, and I don't think I have ever needed drops to examine the long or short sight of a child with Down syndrome. drops sting, and the other aspect that's probably more important, the actual act of holding a child down and putting the drops in can be very, very distressing. Not to all children, but to some children, especially those that don't really understand what's happening. And what that results in is a fear of eye examinations, so that in future the child can't cooperate because they are so afraid of the prospect of drops. And I see lots and lots of children with Down syndrome in my clinic who come because they can no longer go to the hospital because they've developed such a fear of drops. Also, the effect of the drops lasts much longer in children with Down syndrome than it does in typical children. In some countries, and the USA is one of these, the drops that we use in this country, which are cyclopentolate, are contraindicated in Down syndrome. They are not recommended for use in children with Down syndrome because of the risk of toxicity. That doesn't mean that children with Down syndrome get examined without drops in the States. They don't. They just use a different formula. And in fact, they use a much, much stronger dose of a formula that has less risk of toxicity, strangely enough. But you may come across that, and particularly if you're sent home with drops to instill at home, if you read that tiny print on the insert, you might well find that it's not recommended for children with Down syndrome, and that worries some parents. In the UK, adverse reactions are so rare that we don't consider cyclopentolate as unsafe. Hundreds of children every day have those drops. So I would not argue against cyclopentolate on the grounds of safety. I would argue against cyclopentolate on the grounds that it's not needed to examine a child for long or short sight, and that it's uncomfortable and risks the child becoming fearful. That's my argument against cyclopentolate. Now, I did say that dilating the pupil is very important for having a good look at the health of the eye. Obviously, you won't have seen many eyes in this sort of view. That's what the inside of an eye looks like. There's the optic nerve. There's lots and lots of blood vessels coming out of the optic nerve to nourish the rest of the eye. These two eyes are of a typical person. These two eyes are a child with Down syndrome. And it doesn't take much to see the difference. Okay, some children with Down syndrome have eyes that look like typical children's eyes. Some children have eyes that, if it were a typical child, would ring alarm bells. But these eyes are probably perfectly healthy. But children with Down syndrome can have eyes that look very, very different to what we are used to seeing. So my argument is that we need drops for the very first examination of your child's eyes in order to establish what's normal for your child. And if your child's eye looks like that, that's absolutely fine. That can be recorded. It's in the child's records. And then later on, nobody's going to panic when they see that, if you see an optometrist who isn't experienced with Down syndrome. So my recommendation is consent to drops for the first examination of the health of your child's eyes. But if you are concerned about the safety, then you can ask the staff to use low-dose tropicamide, which is much shorter acting and much kinder, if you like. It dilates the pupil without paralyzing the ciliary muscles, so it doesn't change the way your child sees. Thereafter, if you and your child are happy to have drops, I wouldn't try and persuade you otherwise. I believe they're safe and absolutely fine. It's entirely up to you. But if you do have concerns, don't be afraid to refuse consent, because they cannot instill drops unless they have your consent. What might happen is the staff will tell you they can't test your child's eyes for spectacles without drops. What they are really saying is, we've never tried, because using drops is part of their protocol that they have never questioned. Okay? Like, children with Down syndrome are at greater risk of an eye turn, what we call a squint. And there are two types, convergent and divergent. Convergent means one eye turns in, so this eye is looking straight ahead and this eye is turning in. Divergent squint means one eye looks straight ahead and the other eye turns out. Divergent squints are rare in Down syndrome. They are uncommon in typical children, but they're even less common in children with Down syndrome. So the majority of children with Down syndrome who have a squint will have a convergent squint. And then there are fixed squints, and I'll give you an example of a different one in a moment. A fixed squint is always the same eye. So if this eye does looking and this eye turns in, that's a fixed convergent right squint, or a right convergent squint. Now, when that happens, one eye turns all the time. It leads to poor vision in that eye, which we call amblyopia, which you may have heard called lazy eye. It just means the eye isn't seeing very well. And a child can also get amblyopia or lazy eye without a squint if there is a big difference in the long sight between the two eyes, because they can't overcome different amounts of long sight in the two eyes. So they may well overcome one and see clearly with one eye, but the other eye will still be long-sighted, and will lead to poor vision and amblyopia. And amblyopia is treated by patching. I'm sure you're all familiar with the idea of patch the good eye, make the bad eye work, and that usually improves the vision. But patching does not straighten the squint, because behind the patch, the squint is still there. Patching is about improving the vision in the poor eye. And the other type of squint, other than a fixed squint, is an alternating squint, which means that the child can look with this eye and this eye turns in, or the child can look with that eye and this eye turns in. So the squint alternates between the two eyes. And that is the most common type of squint in Down syndrome. It's rare in typical children, but it's very common in children with Down syndrome. And the good thing about it is that the child uses both eyes, but not at the same time. So they don't develop a lazy eye, because both eyes get used an equal amount of time. So children with Down syndrome are pretty smart when it comes to squints. They have the best sort. So you don't need to patch, because vision will be the same in both eyes. Some squints, if you're really lucky, are straightened by spectacles. So the child has a squint when they haven't got their specs on, and they stop squinting when their specs are on. Nothing to worry about. And if not, then one option is just to live with it. Another option is to straighten it by surgery, which they do by tweaking the muscles, tightening one muscle, loosening another, or whatever the ophthalmologist thinks is best for that particular case. Okay, so we know why our children wear glasses. We want to just say a little bit about choosing glasses, because children with Down syndrome have faces that are different to typical children. So specs that are designed for typical children may not fit a child with Down syndrome. They may, but they may not. But that's no reason to end up with specs that don't fit properly. You have probably heard of Erin's World specs, designed by an ophthalmologist who has a daughter with Down syndrome. They are designed specifically for Down syndrome. There's a lot of different styles and a lot of different sizes and different colours. They are metal, which are not ideal for some children. Tomato glasses weren't originally designed for children with Down syndrome, but they happen to fit them really, really well. And they, to my mind, I mean, some people like Erin's World. To my mind, I like funky specs. And tomato glasses are very colourful and therefore funky. And they come in lots of different sizes, lots of different colours, and they are highly adjustable. The sides can be shortened and lengthened and so on, and the pads can be changed for different types of pads and all sorts. They are fabulous. Okay, I want to say one more thing about tomato glasses, because this is something that parents find, it actually applies to Erin's World as well, that parents sometimes find difficult to follow, and that is how much they cost. Now, every child is entitled to a voucher towards the cost of spectacles. And most optometrists will carry a range of spectacles which are fully covered by the voucher, so you don't pay anything. Now, tomato glasses are more expensive. So there are some optometrists that choose to make a loss and offer tomato glasses free of charge. And they just carry that 60, 80 pound, whatever it is, loss, because it's good for their business, because it's goodwill, if you like. Other optometrists don't feel they can afford to do that, and therefore the cost of the voucher doesn't fully cover the cost of the specs, and they don't want to make a loss, so they charge you. They may charge you an extra £30, £60, £80, £100, depending on their business. And it's the same as you go to Waitrose and you know you're going to spend more than if you go to Aldi, okay? Even if you're buying the same or very similar goods. And unfortunately, what this means is if an optometrist very rarely sees children who need tomato glasses, they're very inexperienced, but they can take a loss because they only take a loss once in a blue moon. But those optometrists who are highly experienced, who see a lot of children with Down syndrome, can't afford to make a loss on every child. So they're the ones that have to charge you for specs, which is sort of slightly back to front, really, isn't it? But that's because it's a business and everybody has to make a living. So, I mean, I can't help you choose who to go to. but I'm just explaining why you may know someone who didn't have to pay for tomato specs for their child, and you take your child to a different practice and you're expected to pay something towards them. So now at least you understand what's behind all that. And Specsavers have their own range of specs designed particularly for children with Down syndrome. And I apologise, I don't know whether they make a charge for them or whether they let you have them covered by the voucher. But there's no reason for you not to get a pair that fits your child properly. Right, so the next thing parents always worry about is, how am I going to persuade my child to wear specs? Or my child's got specs and he's refusing to wear them. What on earth can I do? The hospital will think I'm a bad parent. Okay, so let's go through this. First of all, I will bust a myth. Most hospital clinics and many optometrists have a binary approach when it comes to issuing specs to children. And they will tell you one of two things and only two things. Either your child doesn't need glasses or your child's got to wear them all the time. And quite frankly, it's rubbish. Okay, if a child has a squint that's straightened by specs, then the ideal would be full-time wear, so that they only squint last thing at night when they take their specs off before they go to bed. They don't have a squint during the day. But if your child has a squint that's straightened by specs and they're not wearing their specs all the time, don't worry about it, because wearing their specs some of the time is far better than not wearing them at all. So you're doing all right. So don't worry about it. In any other case for wearing specs, other than they straighten the squint, there is no argument for wearing specs full time. That picture is there to remind me to say, if you take your child along to a shop and buy an overcoat, you don't expect the shop assistant to tell you that your child has got to wear specs, has got to wear their overcoat all the time. You wear an overcoat when you need it. You wear your specs when you need them. If you're short-sighted, you wear them to look into the distance. If you're long-sighted, you wear them to look at things close to you. And this is the most important take-home message. Your child's eyes will not come to any harm at all if they're not wearing their specs full time. Not wearing specs does not damage your eyes in any way. So, having said that and taken all that worry off your shoulders, why don't children wear their specs? Well, one reason is because of your anxiety. If you are anxious that they should be wearing their glasses all the time and you're afraid they're not, and every time you pick the specs up, you feel anxious in case they throw them across the room, your child is going to pick up that anxiety. And your child is going to think, oh, I don't want to wear those, they upset my mum. So get rid of that anxiety, stop caring whether your child wears their specs or not, and they are much more likely to wear them. Secondly, some children, and you'll know if this applies to your child, has a hypersensitivity of their face and head. They absolutely hate hats, hair slides, you messing with their hair, having their hair washed. Haircuts are a nightmare, hate anything near their head. Of course, specs are going to be a challenge to those children. And then specs change the way the world looks. We think we're making the world look clearer, so we think we're making the world look better. Your child thinks we're making the world look different. And you remember the children of visual learners, what their world looks like matters more to them than your world does to you. So changing it has a huge impact on them. And then, as I've shown you, specs make things look smaller if you're short-sighted or bigger if you're long-sighted. So you put your specs on, you reach to pick a toy up, and it's not where you thought it was. So what's the child going to do? They're going to take the specs off, aren't they? And lenses always have distortions. And the higher the power, the stronger the lens, the worse those distortions are. So every time your child looks in one direction, the world goes in the opposite direction. Floors come up to meet them. Doorways look like that. Okay? It makes you wonder why anybody ever wears specs, doesn't it? But because we want to make the world clearer and we want the children to learn more easily, we want the children to wear them. So we want them to get used to them. But we do so at their pace and not ours. So we start with very short periods and we build up. Now, if your child has a hypersensitivity, 1 second is a bonus. So if your child will wear their specs for long enough to look at themselves in the mirror, you're winning. Okay? Don't expect any more than that. If they are not hypersensitive, you can go on to this stage. If they are hypersensitive, then 1 second this week, 2 seconds next week, until they are putting up with them for long enough to go on to this stage. And this stage, you choose you choose an activity for which the child will benefit from specs. Watching telly if they're short-sighted, looking for grandma arriving to stay for the weekend out of the window if they're short-sighted, looking at anything close to them if they are long-sighted, or any enjoyable activity with you. It can be just playing a game with you or pulling faces at you, singing nursery rhymes. Now, this is really important. Anticipate your child's tolerance and take the glasses off for them. If you can, never let your child get to the stage where they rip them off and fling them across the room. As soon as you know they're going to do that, take them off for them. Lots of praise. You kept them on for a count of 3 this week. That is brilliant. Well done. We'll do 4 next week. So what you're doing is letting your child have control over their spec wear. And what we're aiming for is your child appreciating that they can see better, they can do the activity better, or make it more enjoyable when they've got their glasses on, and then they will make their own decision when and for how long to wear their specs. And if you go about it that way, many children will end up wearing them full time. But they will only do that if it's their choice and not yours. And it doesn't matter how long this whole process takes. It may be weeks, it may be months, but you'll get there in the end. And if you don't get to full-time wear, who cares? They don't need to wear them all the time anyway. Plenty of people wear their glasses for certain times and not others. They won't come to any harm at all. If your child wears hearing aids as well, that is an additional reason to reject specs because of information overload. Okay, they can't possibly adapt to both at the same time. So choose your aid to fit your activity, and always ensure you've got the hearing aids when you go to pick up their specs, and they've got their specs when you go to pick up hearing aids, because both professionals can adjust one or the other to fit together. So what we don't want to see is something like Timmy here, where his hearing aid is being pushed off by his specs. Right, I do apologise. We've gone the full hour and I haven't said what you might think is the most important thing yet. So I do hope you can stick with me, or if not, you can tune back into the recording afterwards, because this is really important for all of you. This is how well can your children see if they don't need specs, and 40% don't, or if they've got the right specs, that may be long-sighted, short-sighted, maybe bifocals, they've got the right glasses, how well now can your child see? I won't go through how we test your child because you'll know what your child does, but I just want to remind you that we've got so many different tests. We can measure your child's vision, whatever their age or ability. So here we have the detail vision, visual acuity, for typical children of different ages. Don't worry about what these numbers are. These are the numbers that the orthoptist will be writing down, and they don't make much sense to anybody. But what I've done here is arrange the letter chart so it's approximately equivalent to these numbers here. And as you can see, when typical children are very tiny, their vision is pretty poor. They can only see great big things. And their vision improves very rapidly in the first 2 years, slows down a bit, and eventually reaches adult levels, which are these two lines here, and some children do better, at the age of about 5 or 6. This is children with Down syndrome. These are averages, obviously. Starting off very poor, rapidly improving, but never matching typical children, and they never catch up. So at every age, children with Down syndrome are not seeing as well as typical children. And by the time it levels off and gets to the Down syndrome adult level, they are 2 or 3 lines behind typical children. This is children with Down syndrome who also have nystagmus, because nystagmus is more common in Down syndrome than it is in the typical population, and they follow a similar progression, but again poorer than children with Down syndrome without nystagmus, and a lot poorer than typical children. Nystagmus is a visually impairing condition, so this should not come as a surprise to anyone, but this difference may well surprise you. Okay, so at every age, children with Down syndrome have poorer vision than their classroom peers, and you have a right to know that. Now, in my experience, hospitals very rarely tell parents that their children have poor vision. Most of the time, they don't tell you what their vision's like at all. They just say, oh, that's fine. That's what parents tell me. But you have a right to know what their vision is. So what are we going to do about this? Well, we can't change their vision because this is their vision when they've got the right specs. But what we can do is change their environment. So one thing I recommend is that the children use black pen or soft artist pencil, which is very dark. Let me see, right. Okay, sorry, I do on some of these slides have examples of it. I don't know why I've chosen to not put it on this. I do apologize. Okay, which are much, much easier to see. Those faint blue lines on lined paper are very, very difficult for children with Down syndrome to see. And teachers have known for years and years that children with Down syndrome struggle to write on the lines. And it's always been put down to poor motor control. And it's not. It's because they cannot see the lines. And if the teachers make sure the lines they're writing on are black, the children can write on the lines. And this is what happened here with Ben. Ben's mum suggested that perhaps he couldn't see the lines. His teacher drew the lines in pen, and instantly he could write on the lines. So that's a really important message to take to your children's school. When your children are very little, they learn to read with big print. So the teachers probably don't need to make any adjustments to the print they are reading when they're very little. But as they get older and their reading improves, and a lot of children with Down syndrome are very good readers, the print gets smaller and it gets more and more difficult for the children to read. So we need to stress to the teachers that they have to think about enlarging. Now, for fluent reading, we use print 3 to 4 times larger than the smallest print we can read. Think about those inserts in tablets and medicine bottles, those little instructions. Think how small that writing is. We can read that. But if I gave you a book printed in that size, you would really struggle. It would be really hard work. We print our books and newspapers about 3 times larger than those little medicine inserts, because we have learned that we like things bigger than our limit for fluent reading. The same thing applies to children with Down syndrome. They cannot even see the print that comes in those tablets and medicine bottles. Their smallest print is more like our newspaper print because their vision is poorer than ours. So they need to be 3 times larger than their limit, not our limit. And then their contrast isn't as sharp as ours either. So a book like this, apart from being extremely disturbing to my mind, is very difficult for a child with Down syndrome, because this writing is not dark and it's on dirty paper. The children's faces are the same colour as the walls behind them. Very difficult for a child with Down syndrome to make any sense of that picture at all. Whereas over here, the print is on white background, easy to see, nice and big, and the pictures are crisp and a contrast to the background. So be careful what books you choose to read to your children. If they're going to look at the book with you, make sure that it's really visible to your child. Every single child should have poor vision in their EHCP. Some children may be supported by their local VI service, but that depends on the criterion of your local service. In South Wales, where I live, every child with Down syndrome is supported by the local VI service right across South Wales, because they understand that children with Down syndrome don't see as well as typical children, and their job is to go in and teach the teacher that. They don't teach the children, they educate the teacher what adjustments the children need. Okay, I will very, very briefly run through this. This is skimming, not even the surface, skimming the tiny raindrops that have fallen on the surface of cerebral visual impairment. And what this means is problems making sense of your vision even when your eyes are doing all right. And this is something that children with Down syndrome sometimes, or some children, encounter. Not all children by any means, and it's difficult to say how many, because some children have lots of problems, some children might only have one, but the most common issues are difficulty coming downstairs. No difficulty going upstairs, so this is unlikely to be a mobility issue, but difficulty coming downstairs, struggling with steps and curbs, not knowing whether there's a step or not, and changes in flooring. Can't find a toy in an array, so they tip the whole toy box upside down and spread all their toys out before they can find what they want. Can't find mum when she stands with the other parents in the playground. Mum has to go into the classroom and collect them. Can't find one of their friends in the playground. Uncomfortable in visually busy environments such as supermarkets, because it's information overload, too much going on at once. They can't make out one thing from another. And uncomfortable in noisy environments as well, because they can't concentrate on their eyes when their ears are shouting at them. Readily trips over things, so a child you might think of as clumsy might be that they just can't see the obstacles that they're falling over. And has difficulty with movement, that doesn't like fast moving television programs or films, and doesn't like small animals or small children running about. So they have difficulty in the playground, not only not being able to find a friend, but when other children are moving, because they can't judge movement. And then there are much less common problems that occur in Down syndrome, but probably have a greater impact. And that's poor face recognition, cannot recognize anyone from their face. They have to rely on hairstyle, clothes, voice, or something else to recognize who is addressing them. And if you don't recognize faces, you don't recognize facial expressions. So socializing becomes difficult. Okay, very briefly, what should we do if your child has these issues? Recognize that they are genuine visual problems. They're not due to your child's learning disability. They're not due to laziness. They're not due to attention seeking, and they're not due to bad behavior. And the teacher has to recognize that as well. And the way you help your child is to find alternative strategies to get around the problems. And there's two excellent websites that you can go to. If you have any issues along these lines, then please email me. Okay? And there I am. Okay, so I'll stop now. I hope you've managed to stay with me, and I hope you've got some questions. If you don't manage to get your questions across to me for this session, then please write down my email and email them to me. And I promise I'll get back to you. It may take a day or two, but I promise I'll get back to you. Okay, I'm going to stop sharing.